All right. Uh, Welcome to our kind of post-pandemic headache school. We're still in the midst of it, I guess, but we're starting to restart these now. And I think going forward, we're going to have them mostly virtual like this, just through Zoom or some other similar platform. I'm Jared Bartell. I'm an assistant professor at the University of Utah. I just finished my fellowship in headache at the university here. And I kind of have the honor of kind of starting us off and kind of playing a role in being in charge of kind of organizing the headache school from at least for this year. So my first, like kind of the first talk at headache school is just kind of a very basic kind of introductory to migraines in general and some little details about that. That it's going to be different, I guess, kind of from here on out in terms of the headache schools. They're going to be a little bit shorter, like the lecture part. And then after that, we'll have some kind of more audience participation, like Q&A about the talk itself, and then about just headaches in general. The first part will be recorded and shared to YouTube. And then after that, the next part will be just kind of open and not recorded. Like you can, you guys can share your videos and through Zoom, and that's more of like the discussion. So that'll be the majority of the talk, but the first part will just be the standard kind of lecture thing that I'll just, kind of give. And then afterwards there's questions. So, all right, well, let's get started. So let me just, I can't get to the next slide. There we go. So I'm talking about migraines specifically. So kind of things like what are migraines in a general sense, what causes them, like why do we sometimes have them, what makes them continue, and then what do we do about them when we have them? And I'll kind of just go through each of these things kind of briefly. So migraine in general, it's thought of as a disorder of sensory processing. It's certainly the headache itself, but also there's kind of a network of brain functions that are all involved. It's influenced by genetics and the environment. And it's kind of thought of as like the brain kind of loses its ability to control all of its sensory inputs together. It's kind of a nice way to think about it. Migraine affects up to like 15% of adults in the United States. It's actually fairly common. It's more common in women by about like 3 to 1. And then chronic migraine is kind of the longer form version of it, of course. So that's more than 15 headaches per day. Or sorry, per month, more than 15 migraines per month, as opposed to like what we call episodic, which is the less than 15 a month. And a chronic migraine can kind of emerge out of episodic migraine for a number of reasons that we'll kind of go into in a little bit here. So as its own kind of entity, when they look at like kind of large groups of people, there was a World Health Organization study that showed that worldwide migraine is the 6th most disabling condition among the neurological conditions. It was actually the 1st most disabling, just because it's so common. We think of like the disability associated with migraine as due to like really a number of factors, but certainly the pain and the nausea, and then things like light sensitivity and fatigue that can go with it also. But then there's a large component of the stigma that's attached to kind of not being able to do your work, not being able to be as productive at home due to the migraines. People kind of withdraw socially, which is understandable. And then migraine is also linked very closely with depression and anxiety. And these can all contribute together towards the disability of migraine. And then in general, the degree to which people are disabled due to migraine can, again, have like a number of factors, but people's responses to the headaches themselves, like so their pain willingness, or their attempts to avoid or control the headache itself, and then also their engagement in activities can actually play a larger role than how bad the headaches are themselves, the severity and the frequency of the headaches too. But certainly it's all connected. So this is like a fun little comic about headaches. So it's this website, medcomic.com, and I've seen it presented at a couple conferences. But it just kind of nicely illustrates the features of migraine that we often think of. So the pain is usually on one side, it's kind of throbbing. You may see this scintillating scotoma, or like this kind of semicircular pattern of like shimmering or zigzag bright lights, usually kind of flashing, zigzag lines oftentimes too. Um, and that may or may not happen. Certainly, we'll talk about that in a second here. Sensitivity to bright lights or photophobia, sensitivity to loud noises or phonophobia, and nausea and vomiting is certainly a factor in a lot of people's migraines. Um, Notes a few other things here: lasting 4 to 72 hours, which we'll mention in a little bit. And then just thinking about the medicine. So they just mentioned a couple of different classes there, but the preventative or prophylaxis, and then the acute or rescue medicines on the bottom right there. But not all migraines look like that. So these are like the official diagnostic criteria that providers use to kind of figure out, which exact headache type you have. Migraines are kind of strictly considered, you have to at least 5 headaches, 5 attacks to kind of fulfill this. So if you've hadn't had that many yet, then we don't really know it. We need to kind of wait a little bit longer to see what it looks like. But in general, they last up to 72 hours, at least 4 hours when they're not treated. So if you treat it with a rescue medicine and it doesn't last that long, it doesn't mean it's not a migraine. It's just, you just got in front of it before it kind of continued. And then you need to have some other features, but not everybody has all of these features. So somebody that has a headache on one side, it's throbbing, but it's not particularly severe. You can still kind of function, do your thing. You can still exercise to some degree, but it does cause some nausea and, well, plus or minus the vomiting. And you don't have light or sound sensitivity, that's still a migraine. On the other hand, if it's like a very severe headache, it's throbbing, you have light and sound sensitivity but no nausea, that's also a migraine. So things can kind of evolve over time in a single person. Like over their lifespan, they can have different headaches that look like different things, but these are all technically migraine, which makes it hard in a lot of cases to kind of figure out what exactly your headaches are. This is in contrast to a few other primary headache types that I'm not going to talk about today, but I'm sure going forward in the headache school, people will talk about this. So one type of migraine, migraine with aura. You hear about aura a lot on TV, or just doing your own research about headache. But about 1/3 of patients with migraine have some sort of aura. So the most common is the visual aura. So that's seen in about 90% of people. These two little diagrams are kind of depicting what the aura can look like. So it's kind of like a crescent shape, usually, kind of starting either off to the periphery of your vision or towards the center. And then it can kind of move or grow or shrink, and kind of start to become to the point where you can't really see through it oftentimes. And that can be particularly bothersome to people when they can't really see. They're driving, for instance, and they suddenly can't see. That can be quite disturbing. And it's not always there. Even the people that have migraine with aura, sometimes you don't get it every time, most of the time, really. Aura can be other things though too. So we think about things like sensory auras, so numbness or tingling, language problems, slurred speech, difficulty getting words out. You can even have motor aura, or like kind of a hemiplegic migraine with weakness. Those are the least common. And among those people that do get some of these other like sensory or language auras or the motor auras, usually there's some degree of visual component first, but not always. So just as like something to think about in general, but that's often how things will work out. And then in terms of like what the symptoms look like, so we think about positive symptoms as opposed to negative symptoms of an aura. So positive symptoms being like tingling, flashing lights, kind of additional features beyond like your normal baseline. This kind of even goes with like having the light sensitivity, the sound sensitivity, this kind of additional sensitivities to sensations. This is opposed to like having negative symptoms. So if it was a stroke, for instance, you can have like kind of a sudden onset of like weakness or numbness, kind of like taking away a normal sensation. The other distinguishing factor between kind of a migraine aura and stroke is that a stroke can happen very quickly, starting over seconds and kind of being at its maximal intensity within just a few seconds. Whereas aura evolves typically over a longer period of time. It can kind of, for the sensation, for instance, it can kind of start in the fingertips and then over a few minutes can move up your arm. By the end of the hour, or within 20 minutes, or however long yours lasts, it can kind of start to involve other parts of the body too. So that's just a good way to think about the distinguishing points between like an aura and a stroke. So just briefly on the phases of migraine. So people think about having like an aura before the headaches, but even more often, people will have some sort of premonitory symptoms. So things like changes in mood, being more irritable, having some like more fatigue, or having certain food cravings, yawning repeatedly, having a stiff neck, having sound sensitivity. Do we have a new person here? Let's see. Okay, great. Welcome to Headache School. Looks like someone just joined us. So, so just to kind of fill you in real quick, I'm just talking about migraine for the recording part of it. You'll be able to kind of review what I looked at, what I talked about later, but essentially this is the part that's recorded. And then after this, you'll have the chance to ask any questions if you'd like. And we can kind of go from there. But I'll just kind of keep moving forward if you don't mind, unless you have any, if you want me to go back. Basically, we're just talking about migraine as a kind of an entity overall, what it is, what we do about it, why we have it, things like that. But I'm glad you were able to join us. This is great. So talking about the premonitory symptoms, these are the symptoms that precede a headache by usually just a few hours, up to maybe a day, up to 3 days maximum. Then the headache phase itself, which is kind of what we've been talking about. So this can last, again, between 4 to 72 hours, shorter if it's treated, can last longer. Some people go into what's called status migrainosis, which is kind of a persistent headache that just isn't going away. That's a little bit harder to treat oftentimes. And then the postdrome, which is also fairly common, is that people can have some like kind of residual feelings of like maybe a mild, dull, headachy type of a feeling. You can have some nausea, some fatigue. And that can last for like a day or more also. So the causes of migraine, it's never really totally clear what causes any one person's migraine, but we know certainly that there is a large genetic component to headaches, to migraine specifically. So if you have a first degree relative with migraine, you're 3 times more likely to have it yourself. So oftentimes one of our first questions when we talk to you guys is that you have, do you have a family history of migraine, which helps us to kind of work out what exactly is going on with you too. The genetics of it is a little bit complex. There usually isn't one gene that's implicated with migraine. It's usually a number of different genes kind of interacting together. When they do big studies to look at what genes are involved, they usually don't find like a huge consistency between people. There are some families and some conditions that there is like a single gene involved, but that's by far the minority of cases. So there's that kind of underlying predisposition component. And then on top of that, you can have things like the environment and personal factors that can kind of bring a headache out, so like kind of cause the migraine disorder to start. So things like stressful life events, even things like getting married, having a kid, moving, going to school, things like that. There is some evidence that elevation, like going to a higher elevation, such as like from the East Coast, like at sea level up to Utah, like 4,000 feet or higher, that can actually kind of bring on a migraine too, migraine disorder. And then other things like the development of a new kind of a psychiatric problem, like depression or anxiety, or anything else, like even like the development of like a new heart condition, a new lung problem, a GI problem. Those can also play a role. And then certainly head injuries too. That's a big thing that can happen with a lot of people. So this is all to kind of say that you have this predisposition, like the genetic component, and then these other features like the stressful life events, the head injuries, that's all the stress. That's like that's the factor that might get you up to that threshold of having your first migraine. Once there is a sufficient stress to cause that, like to get you into like kind of a migrainous, having a migrainous headache or having those like pre-migrainous symptoms, it takes a lesser and lesser threshold to get to that same level. So it gets easier and easier for your brain to produce more migraines. And this becomes kind of like a negative feedback loop, and it's called, there's a number of names for it, but central sensitization. Essentially, the threshold gets lower and lower for more headaches to happen. This resource part is kind of the things that you try to do for yourself. We try to help you with in terms of medicines, different therapies, to kind of increase that threshold back up, and trying to reduce the headaches from continuing. And okay, and I just see a question. Some of the symptoms, yeah, that you can have all of those phases, certainly. So like the premonitory, the headache, the postdrome, you can have any of those symptoms within any of those phases. So that's definitely something that can happen. That's just like kind of in general, those are the symptoms that tend to proceed in that order, but there's a lot of kind of blurred lines within that. Okay, and I think this next picture should help to illustrate a little bit better also, if I can move on. There we go. So this is kind of a diagram that I presented, I think, in my last talk. I gave a previous talk on chronification of headaches. And this is kind of also plays a role in like when headaches first start, when migraines first start. So again, you have this genetic predisposition. You have, family members that have had migraines or have had sinus headaches, which are often migraines, really, when we look at it. And then you have these additional risk factors. So if you're a woman, unfortunately, that's a risk factor for migraines. Having obesity, having depression, having other stressful life events, those can all be sufficient stresses to get you above that threshold. And then with subsequent headaches, your threshold is actually decreased, like I mentioned. So it gets easier and easier to have a headache. So your attack frequency can influence the number of headaches that you're having beyond that. So kind of headaches beget more headaches. If you're using, if the medicine that you're using, like ibuprofen, Tylenol, even a prescription medicine, like a triptan, like Imitrex or Maxalt, or things like Fioricet, butalbital, those can all, they can work if you're taking them for infrequently enough, but taking them too often can kind of further this negative feedback loop and cause like an additional headache on top, like a medication overuse headache, which is quite common. Unfortunately, we see that in a lot of people. This is all kind of sensitizing you further. Like I said, there's like the threshold is reduced, and so it just takes less and less of a stress in order to get to that same level of headache. And then some protective factors on the other hand. So certainly medicines like that you're on every day, like preventative medicines, being like having a higher education is shown demographically to be associated with fewer kind of chronic headaches. Being married, having a good social support system can certainly be a good thing for headaches and just kind of coping through everything altogether. Exercising sufficiently, managing your stress properly, that can all help. And it's not due to any one of those things, but these can all help to kind of improve headaches overall. So what do we do about migraines? So lots of little things that can all kind of add up to help overall. So again, we're just trying to raise your threshold of headaches a little bit. Everything we can do to make it less likely to have migraines, to kind of space your migraines out, to make them less severe. Each of these little things can help with that a little bit. So trying to avoid triggers. So a lot of people identify certain things as kind of triggering their headaches, like different foods. So the most common one is monosodium glutamate, or MSG, which is kind of its own little primary taste. You have little sensory receptors on your tongue for umami or savory or this monosodium glutamate. It's in a lot of Asian foods. It's in certain cheeses, like just the really savory, usually often like really good tasting things. But that can trigger headaches in a lot of people. Also, nitrates is something to avoid for a lot of people that have migraines. So that's in like a lot of meats, like cured meats and ham and hot dogs, things like that. Other things to do with diet, so trying to eat protein regularly enough. That's an important thing. So eating up to like 10 grams every 3 to 4 hours is what we often quote people. And then eating lots of fruits and vegetables. So that's also important, just to get those vitamins, to get a healthy diet overall. That can help. And then drinking lots of water. Essentially, you're trying to drink enough water to like keep your pee clear, kind of. So we recommend like certain amounts based on what's going on with patients, but just drinking enough to keep your pee clear is really the goal for most people that are having migraines. Getting some degree of mild aerobic exercise daily is always a good thing when you're having headaches that are worsened by exertion, as migraines tend to be. That can be pretty hard, but just doing a little thing just to kind of help your long-term like outcome with the headaches can be helpful, even if in the short term it's not great. So, but especially things you like to do. So if it's just if it's swimming, using resistance band, going for walks, anything that you like to do, because otherwise you won't get into the habit well enough to continue to do that kind of thing. Getting enough sleep, so sleeping continuously in like large chunks at night is really a good thing. If it's interrupted a lot, then your overall sleep quality that night is less, and so you might be more tired during the day. When you're more tired, you're more likely to have more headaches. Um, Other things to consider: if you snore and you wake up in the morning frequently with headaches, or you have dry mouth, that might be a sign of sleep apnea. We always ask about sleep apnea symptoms because that can also play a large role in headaches in general, migraines in particular. Um, if you don't have it, or if you don't know that you have it, but you actually do, that can also cause other health related problems that you'd want to get on top of. So that's just something important to know about. You don't always know that you're snoring either, or you're having these apneic spells. And then mood, like I mentioned, that often plays a role. So just living with chronic pain in general makes most people depressed or anxious, or at least there's some association there. So whether they had a predisposition towards both migraines and depression and anxiety, and these same stresses kind of got above that threshold to trigger clinically significant symptoms of depression, anxiety, headaches. Um, Also, to some degree, the some of the same parts of the brain are affected with both conditions, all of these conditions. So it's typical to have some degree of depression and anxiety. It's almost unusual to not have some of that, but certain some people do. Cognitive behavioral therapy, though, is actually indicated for both depression and anxiety, but also independently for migraines. So we'll often recommend people to get CBT for headaches, for chronic pain, even if they don't have a large depression and anxiety component, because this can be quite helpful for that. Other things we'll often talk about is mindfulness relaxation. There are some apps, on an Android and an iPhone that you can try. Doing some things like yoga or Tai Chi can also be quite helpful to kind of just relieve that stress and trying to stay active in general again. And then just touching briefly on medicines without kind of going into specifics. So we think of the daily preventative medicines and the as needed, like abortive or rescue medicines. Finding a good combination with your provider is often the main thing that we look at when we see you guys in clinic. And then other things just to kind of supplement that too. So FL41 lenses are really great when you have a lot of light sensitivity and you spend a lot of time in front of computer screens or under fluorescent lights. I think a lot of us are spending a lot of time in front of computer screens now with the pandemic. So those can be particularly helpful. You can get those at the Moran Eye Center, which is attached to the University of Utah or affiliated with them. There's also some other versions online that are available too. And then things like a therapy cane, that's these little colorful S-shaped guys there. Those are all really nice if you have a lot of neck and shoulder tightness that trigger your headaches also. Just kind of working on your knots and your tension there a couple times a day can actually go a long way to kind of reducing overall your triggers for headaches. Things like an ice pack helmet or an ice cap is what this one is. It just kind of wraps around your whole head, including the top, the sides. And you can just kind of, put that in the freezer, put it on, lay down, and, you might wake up with a better headache. Again, it doesn't help everyone, but it's something that can be used. I think this particular version can also go in the microwave, so you can heat it, but there are different versions on Amazon and elsewhere that you can find that might be good. Sometimes we'll recommend things like aromatherapy. So especially in kids, we'll recommend these types of things because it's like an easy way to kind of, start with something that's not a medicine. But things like Vicks Vapor Rub that's there, or things like lavender oil, peppermint oil. Some people like to just have that on hand to be able to kind of distract themselves from the pain itself, just to kind of think about something else and, get them out of the moment of the headache and into something else. And then lastly, just other things that we'll sometimes talk about, some FDA approved devices. So like the Cephalate device, which is right there, you wear it on your forehead. Um, there's a vagal nerve stimulator. There's a peripheral nerve stimulator you wear on your arm. These are all kind of expensive, and so we don't always talk about them first. Insurance usually doesn't cover them. They're all considered, for the most part, experimental. Um, but there are also options for people that have migraines too, that are trying to avoid medicines in general. And that's all I've got. That's the introduction to migraine with the first headache school here.